So my name's Sue Kildea. I work at Charles Darwin University. I live in Mbatwa, which is Alice Springs, and I live and work on Central Arundel Land, which is, I think, one of the most beautiful places in the country. Before I get started, I'd like to acknowledge that I am on Central Arundel Land and that we're talking to people who are on lands from across the country that have never been their unceded lands. I'd like to acknowledge the Aboriginal and Torres Strait Islander people that might be joining us today, and also the elders past, present and emerging. And also like to acknowledge Molly Wadaguga, who was the inspiration for the Molly Wadaguga Research Centre, an incredible mentor of mine, a very wise Barada woman from the top end of the Northern Territory. And we have established the Molly Centre in her name to continue her important work, which is all about returning birthing services to Aboriginal communities and Aboriginal control. And it's with that in mind that I'm going to introduce to you Theresa Clasquin. So Theresa is a PhD student at the Molly Centre. She came to us from the position of midwifery advisor in the Northern Territory. So for us, it was an extraordinary coup to get Theresa to give up that important position, which they are such important positions across the country, leading, the midwifery work across the country. And so we were really, really impressed when she gave up that position for a short period of time to come across to us and work full-time on a PhD. Theresa has a background in midwifery, a background in public health. She's worked for Médecins Sans Frontières over in Yemen and in Papua New Guinea, so has that experience of working in very remote and isolated settings and low resource settings, but has also worked in the Northern Territory and provided and worked in Royal Darwin Hospital. So a really great breadth of experience, and we're just really lucky to have her here working really closely on one of our projects, which she's going to tell you more about today. So as we go through, if you've got any queries or questions, please put them in the chat. I will try and moderate and make sure that we can have time for questions, and we'll save them to the end. So Taz, over to you.
Thank you very much, Sue, for that introduction. And it's lovely to see you all joining online today, and lots of, colleagues that have all inspired me along this journey. So I'm really, really pleased to be here. Now, as Sue has mentioned, I am completing a PhD with the Molly Wadaguga Research Centre. And my area of interest was really, how do we support for birthing on country services, and how do we return this to community control, but do that in a way that really optimized both the midwifery workforce and also recognized the broader sexual and reproductive health needs of First Nations women in community. And so the topic, or the area of focus for my PhD, ended up becoming about how we could look at a life course approach to addressing the sexual, reproductive, maternal and newborn healthcare needs of First Nation people. And I've chosen to do this in a very remote community in the Northern Territory, and I'll talk you through why as we progress. But before we do that, and as Sue Kildea has already done as well, I'd also like to acknowledge that I am joining you here on Larrakia country, and I'd like to pay my respects to the Larrakia elders, both past and present, and also extend those respects to any First Nations people that are joining us online today. I also want to take a moment to acknowledge that I couldn't do this work if I didn't have the leadership, the strength, and the absolute bravado of the senior Yolngu women in Galawinku community. And these women have called for the return of services and given us an opportunity to partner with them as allies in this critically important work. And if you've ever had the opportunity to spend time with people like Professor Larapa Mayapalama or Rosemary Gunjanamboy, you'll know that there are not women who could be more inspiring to follow than they are. So I particularly acknowledge them for their leadership and their strength, and for their patience as I walk with them on this very important journey. So very briefly, Sue's kind of given you a snapshot of who I am. But basically, well, one, as you can see, I'm a very proud auntie, and it's probably one of the greatest roles that I have in my personal life. And I'm an auntie to both my blood nephews and also to many nieces and nephews from my very close friends. But I've had also the opportunity professionally to work in a huge number of settings. And Kildare already, gave you some insight. I have worked with Médecins Sans Frontières, which allowed me to work both in the autonomous region of Bougainville, which is off the coast of Papua New Guinea, as well as in the Yemen at the very beginning of the civil war. And beyond those experiences, I've also been able to work here in Australia in very remote communities, work as an academic and as a leader. And throughout all of these experiences, they've really shaped my professional understanding of both the enablers, but also the challenges that we face within this space, and have driven me to where I am today as to why I think this work is so critical and why really I chose to do my PhD. But I also want to just acknowledge that we are all here because of people that have supported and loved us in the process, and a particularly huge shout out to both my mother, my grandmother, and to my close friends for their love and support through this journey and the many bizarre choices I've made in my career. So, as we said, today's topic is really about why a life course approach to birthing on country is critical to ensuring reproductive justice for remote First Nations communities. Now, before we track into talking about what that is, let's have a quick definition activity so that we all make sure we're talking about the same thing. So when we talk about a life course approach, that's an approach when we recognize that actually we need to partner with women from their first menstruation all the way through menopause, because actually women need that same level of continuity, attention, and care across all of their sexual and reproductive health choices. So when I talk about a life course approach, I'm talking about a model of care or a way of providing care that recognizes that we need to work across that journey. Birthing on country, for those people who aren't familiar, is a metaphor really for the best start to life. But as Kildare again mentioned, it's really about how can we redress the impact of colonization and other harmful components and return birthing and other women's health services, not only to First Nations communities, but to their control. And I'm going to come back to reproductive justice because that deserves a little bit more thought and time as we progress. So I'm going to let you hang in there while we move on to the next step. So first and foremost, as you said, I live and work in Darwin, and I spend most of my time between Darwin and Galawinku, which is my study community. And I'll talk to you about that a little bit more. But before we do that, it's a really good idea. Oh, hang on a second. We'll come back to that in a second, to talk about what's happening in the NT. But before we kind of do that, I actually want to stop and check in. And thank you, Kildare, for volunteering to manage the chat box. Because first and foremost, I'm going to ask everyone online to stop and share your emotions. And MS Teams has provided us with more emotions than Brene Brown has. You have many emoji options to chip in. But tell me how you feel when we talk about establishing birthing on country services in a very remote First Nations community in Australia. Give me an emotion. And it's okay for us to be two-faced about this issue, because maybe you are excited and you're committed to that journey, but you may equally be really anxious. So let's see how everyone is feeling within that space. And what we're going to do is we're going to come back and revisit that as we get through the presentation to see whether or not our views and perspectives have changed. And maybe they have and maybe they haven't. But as I said, before we kind of get into it, the first thing I wanted to do was really talk through where we are in the NT, and particularly start where a lot of these conversations start, which is around perinatal outcomes. And when we have a look at the page in front of you, this is not a pretty picture. So we see that First Nations women in the Northern Territory are far more likely to have poorer outcomes across their sexual and reproductive life. We know they're far more likely to have higher rates of unintended pregnancy, didn't access or engage in care, have poorer perinatal outcomes, as well as some of the stuff across their reproductive component, for example, higher rates of both women's health cancers, but also deaths related to those cancers. And so when we start to look at this, we can go back to our little emoji thing and think, how do we actually still feel about remote birthing on country? Because this actually maybe is risky business. But what we need to do when we're having this conversation is remember the context within which women are experiencing these outcomes. And the most important thing for me is when I look at this particular image, there are two kind of big things that jump out at me. So one, the degree of remoteness that exists in Australia. And we need to really stop and think carefully about that, because we're all anxious about returning care to these places, but these places, from a geography perspective, make up the vast majority of Australia. And from a statistical perspective, we know that 1/3 of all Australians live in rural and remote areas. And so we really can't leave these people behind to create these kind of coastal or seaboard components of service access without considering the needs of those people in rural and remote. And if you look at the diagram to the right, that's a mapping of the distribution of maternity services. And you can see the reference down below if you're interested in reading the article. But when we look at both the remoteness and then the distribution of maternity services, we actually start to see a very different picture, which starts to suggest to us that actually, when we make statements like 16% of First Nations women did not engage in recommended antenatal care, we're actually remembering that these women are not able to access that care. And that flips the table, because that takes it away from inferring that someone doesn't want to engage in care to the fact that we're actually not providing that care. And we know that this has been found in the research. If you think of Z's work, for example, which found that basically the quality of care in remote community did not meet both the cultural and clinical needs of women in that community. And so no matter which of these domains you start to look through, we can actually see that although women, or some First Nations women, do experience these poor outcomes, we also, as service providers, have failed to provide them the basic access to these services. And that's why we're here to talk about this topic today. And this is why the conversation of birthing on country is so critically important. And it's because it's not just about addressing the remoteness issue, it's also about addressing the acceptability and quality of care. And that's where that birthing on country metaphor is so critical, because we're not just returning care, we're returning care in a way that enables First Nations people to be leaders within what that looks like and how that can integrate and empower their cultural knowledge as well. And so what we can say based on this information is that actually in Australia, access to sexual, reproductive, maternal and newborn healthcare is disparate. As in, some of us can access it and some of us cannot. And now we know that actually those people that live in rural and remote communities are really disproportionately affected by this, because they're the people that can't access this care. And whether we're talking about having a baby in community or being able to access early medical termination of pregnancy, the deprivation of providing accessible services that are acceptable and high quality means that women are more likely to experience poorer outcomes. And this suggests to us that what we need to do is go back and rethink what we've done. How have we allowed the situation to happen? And what is it that we need to do to move forward and redress? But what this ultimately speaks to is what is called a reproductive justice issue. And reproductive justice has come from the United States. And basically it recognized that although we have reproductive rights, which is our individual rights to be able to access, contraceptive care, have an abortion, for example. But what we learned, and particularly in the American and then Australian context, was that not all women are able to access and practice those rights. Sorry, I have a noisy study buddy in the background. Hopefully she'll keep her opinions to herself. And so what we know is in the Australian context is that One, First Nations people, particularly in the Northern Territory, are far more likely to reside in rural and remote communities, and therefore they are disproportionately affected by a lack of access to services and a lack of access to culturally safe services. And so reproductive justice is a really good framework to articulate the fact that although we all have reproductive rights, some Australians are not able to practice those rights. And that provides a really good framework into which we should be looking towards a solution. So very quickly, how did we get here? And I've got a very funny photo in the corner there because this in part tells us how we did get there. This is a photo in Yemen, and this is a group of men who managed to get our four-wheel drive stuck in the only puddle of water that existed in the entire country. And only really because they were so impressed to see the water, they wanted to test the Land Cruiser out. Completely avoidable situation and made us very late for our clinic. But how did we get to the situation that we're in here in Australia? So why do we not have services in some regional, rural and remote settings? And there's a number of things that happened. Predominantly, it was because we went through a process of what was called the centralisation of healthcare. And particularly that occurred within both obstetrics and midwifery. And what we saw was the creation of specialised hubs of care that pulled together these specialist obstetricians and midwives, and we located them in central hubs in big urban areas so that we could provide everything that everyone needed. And if we think of Monty Python, I know it's kind of not the thing we talk about anymore, but the machine that goes bing is a very clear descriptive of that process of what we did in the specialization of care and how we created systems that really could only be built and sustained in an urban setting. And over the course of the last 3 decades in the process of this centralization, we've seen the closure of 50% of all obstetric and midwifery units in the country. And most of those closures have occurred in rural and remote communities. Now, at the time, there was a promise that this would bring improved quality and safety for perinatal outcomes. But what we've learned over time is that actually we haven't seen those promised improvements. And rather what it did was reflect a risk ideology that we had adopted as healthcare professionals that made us really reluctant to allow people to birth in places where we didn't have absolutely everything. And if you think about the 1% rule, which Dick Cheney made so famous in his statement, where he said that if there was a 1% chance that scientists were helping produce weapons for terrorism, we should treat that 1% chance as absolute certainty. And overnight, with 9/11, the risk conversation in the world changed dramatically. And we kind of in obstetrics adopted this very similar approach of if there is a small chance that something should go wrong, we need to make sure that we have all of these things around to absolutely manage and make sure we have a really good outcome. And so we have to stop and rethink about that because that's probably not a great methodology and it obviously hasn't helped us in getting to where we are. And lots of other things happened. In the process of the centralization and sometimes the isolation of practitioners, we also saw a workforce that had felt that they'd lost the skills and competency to do those kind of care. So what we've seen more recently, though, is this issue has been brought to national attention. And that's through the national inquiry that was around exploring the availability, accessibility, acceptability, and quality of sexual, reproductive, maternal, and newborn health services in Australia. And they literally named it Ending the Postcode Lottery. So let's call a spade a spade. This is about the fact that some Australians are able to access these services and others are not, and that is purely determined by where you live. Now, they made 36 overall recommendations, which are worth reading, so I highly recommend you do that. But these are some of them that are really pertinent to the conversation of birthing on country. So we know that we actually need to start incentivizing and empowering the scope of practice of our providers. And that's not just around GPs, that's our nurses, that's our midwives. And we also need to be thinking about our First Nations workforce and how we can really empower that workforce to fulfill these roles and responsibilities, particularly in a remote setting. We heard that we need to enhance access to things like the MBS and the PBS. And in some sense, they're so medical centric. We want to make sure other healthcare providers can access those full range of items and therefore be remunerated for the care that they provide. And the recommendation, most importantly, said that we need to ensure that maternity services, including birthing, is available, accessible, and acceptable for all pregnant women. And it made a second statement after that, where an emphasis needs to be placed on redressing this for rural and remote dwelling women. And finally, it spoke to that piece of acceptability and the need to develop a workforce that were both trauma-informed, culturally aware, and safe to be able to really provide services in partnership and in respect of women. So what do we do with this information? Because it's kind of great to be given 36 ginormous recommendations to change the world. And a lot of people are all sitting and scratching their heads to figure out, well, how exactly do we do this? And this is where I see the opportunities and what's helped me identify my PhD as part of that, that opportunity to really reestablish services in community. So it's about recognizing that we have failed some people's healthcare rights, and therefore we need to go back and embed a health rights approach to service delivery, where we no longer choose and decide what we do provide, but we actually provide services that reflect the community's needs. We need to enable remote service capability. So that's that workforce piece, but it's also around infrastructure and other community component pieces that enables that remote centre or rural centre to actually stand up and do this important work. Most importantly, we need to empower First Nations women and girls to be the leaders and the architects in how this looks and how this happens. I would not be here today if I was not part of many who are answering the call of the Yolngu women in Galawinku. They are leading and I'm walking with them. My job is to identify and address the balanda or system issues that are preventing them from achieving this. But without them, we really wouldn't be able to do this work. And the final thing really is that we need to potentially re-envision who we are as midwives. And this conversation is going on around the country right now with the Future Midwifery Workforce Review. But from my perspective, in the rural and remote context, there's an opportunity to re-envision continuity of care and to think about our role to partner with women across a much longer duration of their life, so that we can be with teenagers and help and walk with them through their first menstruation, their decisions around when they want to have sex and what contraception they're going to use, through to that point of menopause. So that's a brief introduction, I guess, of what's the problem and how do we move forward. And I've whacked a little Rubik's Cube up here. For those that know me, they know I love a Rubik's Cube and love solving a Rubik's Cube. But really what this speaks to and why I wanted to raise it is we know that there are many, I guess, well, I'm going to call them myths, but they're risks that people feel are preventing us from doing this work. And sometimes when we talk about birthing on country, we have a tendency to over-articulate or to dominate the conversation around medical risk and how we manage it. And for many of us, birthing on country may seem like a very unachievable thing. And it's quite similar to if I was to ask you to solve this Rubik's Cube now, you'd be like, yeah, sure, Tez, like, nah, I can't do that. But actually solving a Rubik's Cube is one of the easiest things you can do. All you need to know is the algorithms to solve it. And what we know with birthing on country is we already have some of those algorithms. So Sue Kilday and other members of the Molly Wadaguga Research Centre have done incredible work in both Brisbane and New South Wales and Alice Springs, and we're starting to see the benefits of birthing on country models of care when we partner with First Nation communities. And we can use those algorithms, most commonly through the RISE framework, to help guide how we're going to do this work on country. And what I really want to leave with you is to remember when we go into these conversations of risk or difficulty, make sure that we're stopping and checking ourselves and checking our professional egos. Because what right do we have to dominate the conversation with medical risk when we also know that women have other things they need to think about? And most importantly, women have strengths. And we have to take a strengths-based approach to how we deal with the solution. And we need to give space to women to be able to understand the broader risks they face and to support them in their choices. And so where this takes me to really is my PhD, and where I see the opportunity to support the Yolngu women in Galawinku to move this forward. What I haven't talked to you about is the policy environment, and I was going to, but the fact is there are so many policies at the national and state level that tell us to do the right thing, and yet we haven't done that year after year after year. And so what we have to do is go back and look at these policies and actually say, how did we write them? And are they actually accessible in the practice setting? And do they allow us to do the work we do? I have a particular interest around clinical service capability frameworks because they are the overarching policy document that delineates how we provide care. They tell you what machines that go bing you need, how many doctors, a surgery, and all of those resources. But what we want to know is how can we rebuild or reframe these policy documents to ensure that they actually can be used to support the establishment of First Nation-led models of care on country. And how can we do that in a way that's going to meet our collective needs of safety, but can also ensure sustainability of services, particularly in those very remote settings? And so my research question, it's a little bit longer, is literally what are the resources required to establish primary levels of sexual, reproductive, maternal and newborn health care in a very remote community. Partnering with Galawinku is important because they called for this service, but there are benefits to doing this work in a very remote space because we know that if we can do it there, we can replicate it anywhere. And so writing a roadmap or a clinical service capability framework for a place like Galawinku hopefully gives us the foundation to replicate this work further down the line. And when we look at capability frameworks, we know that they kind of give us a lot of detail. They tell us how many nurses we need, what skills they need, whether the doctors need to be there, whether you have access to surgery and what kind of technology, et cetera, is going to be there. But my PhD wants to make sure that we also integrate cultural knowledge within that framework. We need to stop writing our policies purely from a Western perspective, and we need to start partnering with our communities and considering and recognizing the equal value of cultural care in ensuring positive experience and outcomes. Very quickly, for those who are not familiar, this is what a clinical service capability framework looks like, and this is what it looks like in the Northern Territory. So when I'm talking about primary levels of care, we're talking about level 1 and level 2. And now a level 2 shouldn't be unfamiliar because that is what is called a primary maternity unit. And we know that that's the gold standard of where all midwives should work. So the question is, how do we do this in Galawinku? So the way I intend to do this work, as I said, I'm working in partnership with Galawinku, and I'm using a participatory action research methodology to partner with the Yolngu cultural care providers, and they're Jackameers. Anyone who hasn't seen the film should definitely jump on and do that, as well as a broad range of NT Health, the Aboriginal Community Controlled Health Sector, and NGOs to make sure that we can collectively identify the resources to create services in Galawinku and do that in a way that we can replicate that in another community. Now, this project has a really strong governance framework, and that's critical to the work we do. So we have a female Yolngu governance board on the island called the Gurmo Dangi Yunamia board, and they provide all of the overarching guidance into the work that I do. So they approve my methodologies, they help facilitate the research, they'll lead most of these conversations to make sure that we're walking in the right direction. And what we want to do when we bring together all of these various stakeholders is make sure that one, they can hear and listen to each other, but two, that they're remembering that they actually have a role and a responsibility to make this work. We have to meet people's healthcare rights. To do that, we need to make services available, accessible, acceptable, and of high quality. And so we want to use these rights-based frameworks to support the group in identifying what that looks like. How I'm going to do that is in a series of studies. So I have bitten a big chunk of work off to do in my PhD. And for those that know me, they won't be surprised that that was my choice. But what we want to do is work through some of the components of sexual, reproductive, maternal and newborn healthcare, and particularly the ones where we know there have been barriers to service provision. And I want to address them in individual studies. So first off the mark is sexual assault care, and then basically we'll move on to family planning and abortion care, and then on to maternity and neonatal care. And it's really important that we're taking this stepped approach to do this work because they are all worthy of our time and attention, but there's also critical work that has to happen with each of those services to support either the healthcare providers or the community to understand how we can establish that type of service on country and how that can be done with the Yolngu leading the way and the rest of us coming behind to make sure that we're securing all of the things necessary. The way we want to do this is kind of the methodology that I'll replicate in some way, shape or form across each study. For each study, we have gone and talked to Yolngu women in community. I'm not trying to understand their lived experience of accessing an abortion or having a baby, but rather we've asked women what they aspire for. What is their vision for the future? And their vision is bright. I have every single person you talk to, they can talk about this incredible vision where Yolngu women are caring for Yolngu women and what that will mean for them in the future. And we want to use that vision to ground the conversations that both our Yolngu and our healthcare providers are then going to have. And we do that through a workshop series where we're going to invite all of those stakeholders to sit down at the table and to basically work through the co-design process of identifying the resources to be able to establish care on country. Now, for some areas like maternity and neonatal, we know there is a clinical service capability framework. Each state and territory has one, and we used to have one at the national perspective, although that's not currently available. But there are other services, for example, sexual assault or termination of pregnancy services, where this information is not commonly articulated within a clinical service capability framework. And if we don't articulate it, that's concerning because really these documents are designed to delineate and to direct the type of care that a health service delivers. So we need to pay attention to this silence in these spaces and make sure we can articulate what are the expectations of both level 1 and level 2 primary sexual, reproductive and maternal and newborn healthcare. And what we're going to do is through that workshop, help the collective identify or test those clinical service capability frameworks together. And we'll come back to them once they've done that work using standard PAR processes to make sure they're happy with the final product. And then the intention really is to take that document and to engage more broadly with the NT health, safety and quality components and seek endorsement as the system manager for health service delivery in the Northern Territory. Because we want this framework to be accessible not only for Galawinku, but for Maningrida or Wadeye or any other community in the Northern Territory. And we want to empower both the Northern Territory government and the Aboriginal community-controlled sector to do this absolutely important and critical work. We're going to come back to our risk and safety conversation and have another think about our little Rubik's Cube. Because what we need to have in these workshop series is some really healthy discourse. There's no value in sitting at the table if we can't speak one with truth and also speak to our fears and those components that may be driving what's happening. So what we hope to do by bringing those groups together is to give them the opportunity to use that dual knowledge approach to both service and policy redesign. And part of doing that is helping them collectively identify and then managing those risks. And like I said with the diagram earlier on, when we talk about risk, part of the exercise is actually broadening all of our understandings of risk. It's about us as medical and midwifery providers recognizing there are other risks in women's lives and there are other strengths as well, and equally helping the Yolngu understand some of the concerns and components from the Western healthcare system. But most importantly, throughout that process, we are also going to make sure that we have the right people at the table so that we can have both the subject matter expertise and the evidence to guide best practice and decision-making throughout that process. And really where that's going to take us to is hopefully that end product of a level 1 and level 2 clinical service capability framework that can give us that roadmap that tells us how to do the Rubik's Cube so that we can establish care on country, and we can do that in partnership with our First Nations people. So we're going to come back to how do we feel. Now, unfortunately, I couldn't see any of your emotions earlier, so I'm going to take it that everyone was in the top right-hand corner of super excited and can't wait to do it. No, not even Sue Kildare was there. So, and that says something.
No, I was definitely there, but I've looked at them, Tez, and it was probably about, maybe half-half. There were a few people that were super excited. Quite a lot of people didn't play the game, but some people were mixed emotions, and others were a little bit unsure and possibly worried.
Cool. And look, I don't intend by this point that I've won you all over, because that's not the goal. The goal is for us to continue this conversation, and not even if the context of remote doesn't apply to you, when you go back to your workplaces, the broader component of how do we meet women's sexual and reproductive health needs is a really important conversation. If you work in an MGP or you work in a postnatal ward, how well do you partner with women around their contraceptive options after birth? You know, and what is it that we can all do to, one, work to the scope of our midwifery practice, and two, really optimize how we can partner with women across that life course. But I am very keen to get you all to post up again now how you're feeling. I don't intend that I've changed many of your minds, but it is an interesting exercise to see whether having the conversation has given us the opportunity to reflect a little bit. So what's it looking like, Hildy? You're on mute, mate.
Some people are super excited. Probably a bit more positive than previously, to be honest, with what people have said so far. So, yeah, a little bit mixed, but probably you're probably suffering from my lack of knowing what emojis mean what. But I think there's quite a bit of excitement by the looks of it. Yeah. Well, so did you want to keep going, Tez, or is it question time?
Yeah, very close to question time. So thank you, Kildare. I am going to hand back. Well, I was going to, but I seem to have lost the ability to use the screen changer button. 2 seconds, everyone. There you go.
You're up.
So I want to leave you here, and I do want to open up for questions so that we can, if anyone would like to say anything, but I do want to leave you with kind of where I started, which is do not forget that First Nations women in these communities have been providing this care for 60,000 years. And not only that, but I can tell you that no one in the Molly Centre is able to work to keep up with the expectations and pace of our Yolngu colleagues in Galawinku. When I go and say to them, guys, let's look at sexual assault services, they're saying, let's go to the school today. We want to go and talk to the young people, and we want to make sure that people understand consent. And so if anything you can take away from this is take away the unbelievable leadership and strength that we have in our communities, and the confidence that these women know how to take care of their families and know how to take care of their community. And I'm going to open it up to any questions or comments now.
Thanks, Tez. I'll keep an eye out. If anyone's got any queries or questions, please put your hand up or put it in the chat. At the moment, there's nothing in the chat. And I'll just wait a little bit longer to see if anyone's got their hands up. I think, Janine, did you have a question? Looks like you've come off mute. We can't hear you though.
But we would love to.
Can you hear me?
That's better. Yeah.
I've just loved listening to this. The goosebumps all over my body. I worked in a remote community and I delivered a couple of babies in Central. And it was so special because those children will always be special. They've got their own dreaming. And it's just, I find I just butt my head all the time. I've been a home-based midwife back in New Zealand. I'm a very autonomous practitioner. And working here in Australia, I feel like I'm butting my head with the medicalised, and doctors are turning pregnancy, birth into a disease.
Mm.
And it breaks my heart. And I've just been in a bad place lately where my head has been banging and I've had to leave my job because I wasn't allowed to be an autonomous practitioner. I wasn't allowed to use my own clinical judgment and my own clinical skills to be told that you need to do ops on these women. They're not sick. She's had a baby, and it's just those little things that's just making everything so medicalized. And let's bring it back to our knowing of midwifery and just celebrate women.
Thank you, Janine.
Yeah. Did you want to respond? Yeah.
Yeah, I think firstly, just thank you for sharing with us your personal experience and the trauma of what it is to be a midwife, but not being able to do midwifery. And I think that is what has come up at the national conversation at the future midwifery workforces as well. And in some sense, when we look at those policies and guidelines that tell us everyone should have continuity of care, it feels like a gaslighting experience because we go back to our workplaces where we aren't able to provide what we know is the best way to partner with women. I really acknowledge your pain in sharing that, Janine, but I also hope that you can find a future in one of our birthing on country services, because it is people like you that we need working in partnership with our First Nation community providers.
Well, I'm in the top end of the NT at the moment, so...
Well, careful. If you give your location
Des,
away, Kildare will find you.
Des, do you want to stop sharing? And if anyone feels comfortable turning their cameras on, it'd be lovely to see people and see if there's any more questions. But yeah, if everyone can just pop their cameras on for a bit and we can see who's out there, it'd be great to see everyone.
Yeah, unfortunately, Tyler didn't explain how I stopped screen sharing. So hang on. Oh, wait, I think there is a button. No, I found it. Okay, I promise I have technological skills, people. All right.
That's great. It's much better seeing people's faces particularly when there's questions being asked. So can I just ask, does this kind of discussion make anyone nervous or make people think that this is just crazy stuff and it's never going to happen? Is anybody worried in that way? There were a few kind of emojis that made me think that there might have been some people that were thinking that this might be pie in the sky or just too dangerous to even think about, but nobody wants to say anything or explore that.
I'll say something.
Right.
I get a bit nervous. I do retrieval in the top end with CareFlight, and I get very nervous about 3 a.m. complications. And it's stressful beyond belief when you've got a mother and a baby potentially either in utero or ex utero to retrieve at that time of the night, knowing that often complications happen in low risk women where it's not expected. And I think just the inconsistency of staffing in the area, and just makes me a bit nervous as well.
Thanks, Penny. I think those are super valid thoughts. And I think what we want to do in this conversation is create space for people to talk this stuff through, because until we can identify it, we can't manage it and we can't figure out what the alternatives are. And I think part of the conversation about delivering a capability framework, a huge part of that is related to exactly what you do, which is retrieval. So how and what is the role of retrieval services, and how do we support safety across the system? So it needs to be safe for the midwives in Galawinku, but also how do we support the workforce in Care Flight or RFDS, who will have to transfer some of these women to either Gove or to Darwin. And I think it comes back to scope of practice, but it also comes back to what is it that we need to do to support the workforce to gain the skills, the knowledge, and the confidence to do this work. Because you retrieve babies already, and sometimes they're not well babies. They might be preterm babies, or babies born too small as well.
Yeah. I think it was just sort of, complications that happen during labour and birth, when the stakes are a bit higher, as opposed to pregnant women who are kind of early labouring, or babies already born and they need to be moved for, reasons X, Y, and Z. It's kind of when unexpected complications arise during that birth labour period. I mean, at the moment, we've got a weather issue just getting into places, and I think this is fabulous, and I think it's just going to be awesome. But and I guess, when you're looking at the big population, you're kind of only looking at maybe a small number where things might go wrong and stuff when you're kind of looking at the big numbers. But it's just a stressful thought of having just those labouring birth complications, when the stakes seem a bit higher, and it's always middle of the night, always.
I think those are super valid things, Penny. And I think that second last slide where I talked about the process of risk clarification, that's actually what we need to do, because part of the problem right now is when we think risk, we're not very specific about that risk. So we say, well, what about the complications? Well, actually, there's evidence that's going to help us say, well, the complications we should worry about in well women is PPH, for example. And so once we know that risk, we can start to say, well, how do we control that risk, and what are the skills and competencies someone needs to do to manage it? And hopefully, by bringing all of those people, including Care Flight, to the table, we can start to actually understand that risk. And once we understand it, we can better plan for that change. And I've noticed a couple of other comments, if you don't mind, Penny, have come up in the chat box. We just want to see if anyone else would like to. Yeah, Summer, I'm not sure if you wanted to share your thoughts, or if anyone else had any other comments. It's great to see so many of our Northern Territory people here. You are not Summer, but it's lovely to see you.
Hi, sorry, I'm actually using Summer's login or invite, and I thought it wasn't really fair to make a comment and not put my name on it. But I think it's not just in the Northern Territory, but across Australia. We're doing a lot of harm to women, and by putting them in hospitals and by making it a medicalised service. And we don't seem to, we don't measure morbidity particularly well. So, it's a balancing act, is how I see it anyway.
Yeah. And I guess, so do you mind just telling everyone who you are? So you're the manager of?
So I'm the manager of the Darwin MGP.
Yeah, lovely. And so, although that model of care has managed to create some degree of continuity for our women from remote, we kind of know it still falls short, really, in the sense of what it could do, particularly if we could improve that continuity across the spectrum. But yeah, it's really great.
Yeah. I think there's lots of really exciting opportunities, but I think there's a lot of work that needs to be done in this space, and it needs to be, I think people pay lip service to the idea of continuity, but we're not doing it.
Well, Vanessa, we're all here with you as to how we can improve that continuity across the Northern Territory, because we can't just do something for Galawinku. We need to change this story for many other First Nations communities as well. So glad to have you up here in the top end and hopefully helping us take some better positive steps moving forward.
Thank you.
Taz, can you see people's hands up?
No.
Okay, Janine's got a hand up, and then I've got my hand up as well. So Janine, did you want to speak to something?
Can you hear me?
Yes.
I just feel as though we're growing our midwives now to be scared of birth. You know, we talk about all the risks. Well, actually, the risks are small. Majority of births and labours are quite normal, and just looking at that continuity of care, I lived in a remote community for 3 years, and over that 3 years being the continuity carer for all those girls in that community, yes, I missed out going into Alice Springs with them to deliver their babies, but I just could see the difference of the care model by the end of the time I've been there. You know, the midwife before me was like, you know, you need to text the women, you need to remind the women to do the blood sugars. No, let's empower the women to do their own blood sugar, you know, empower the women to come and see me, not making them come to see me. And by the end, you know, women were going for their sit down and they've seen me 25 times before antenatally, you know. They were coming to me for preconception care. And yeah, and that was just that continuity. I gained the trust of that community. I gained the trust of the older women in that community, you know, and that's, so how do we retain our staff in these communities as well?
Yeah, thank you, Janine. I am going to go to Kildy, but I guess part of capability frameworks is talking about some of those critical components of how do you grow your workforce and how do you support them to do the work. And we're looking for the opportunities around, you know, what is the professional training and development they need? What's the clinical supervision or cultural supervision they need? And what's going to help them be able to be sustainable in these settings? So thank you for your comments, and over to you, Kilday.
Okay, we've got about 6 minutes before we wrap up, and we always like to finish on time because it's important for everyone to acknowledge that you've shared this hour with us. But to keep to time, I think I just want to address something that Penny was talking about, and it is that fear of things going wrong, which is always underpinned not our policy, because I think, as Tez said, in Australia we've got beautiful policies around what should happen, but it's more about our practice, and our what underpins our practice is always the fear of something going on and the belief that women are going to be safer in the large tertiary settings. But the evidence we have from overseas, it's not huge evidence, but it's mostly comes from Canada, and it's remote communities that have returned birthing services to their very remote communities that are sometimes snowed in and you can't get a evacuation plane in anyway. Sometimes it's just impossible to do retrievals, but they still have returned birthing service, like Pavugnatuk in northern Quebec returned birthing services in 1985 and has had 3 very large evaluations since then that have shown that when things do go wrong, they can be managed very well in the primary care setting, and that actually the screening and the way women are cared for actually reduced the chance of complications happening, but also they were able to be managed and retrieved in a way that was safer. And it always, if you're bringing a service back to a remote community, for those women that are already experiencing things like preterm birth, having a service on the community will actually ensure that that primary care they get when they're in the remote community is provided by somebody who knows what's going on. So a trained, skilled midwife who's able to make sure that the first care that they get is the care that's appropriate for their condition. Not, and as we know, sometimes women might have to wait hours for a plane to get there. So in my experience in remote, whenever we needed somebody in Maningrida, the plane was always in Wadair, and you had to be able to manage a lot of things there, and very rarely is that leading to adverse outcomes for the mothers or the babies, because often if you're in a remote community like that, that when things are going a little bit slow, you have to call the plane sooner than you would if you're in a home birth situation and only 20 minutes to the hospital. So there is reassuring evidence, but we've never done this in Australia. Well, not for a very, very long time. And the crucial thing about what's happening in Galawinku is we are working very, very closely with the Yolngu leadership and colleagues to ensure that we're really incorporating Aboriginal knowledges and the skills and knowledges of the Aboriginal women through the Jackamere, that the training is not just about the Western doula training around what should happen in pregnancy and childbirth, but it's very much around the Yolngu training about what should happen to help support women in pregnancy, in birth, and in the postpartum period. So I think that gives us an added benefit that is just not there in a lot of our hospital systems today. And it was Vanessa who said that we're unfortunately harming women and families in our current hospital system. And I think that's what's leading to what Janine was saying, where midwives are feeling, many are walking away from the profession. And unless we can turn that all around, not only in our remote communities, but actually across the whole maternity system, we're going down a really bad path at the moment that just got exacerbated by COVID. So we need to actually turn things around across the whole of the system in Australia at the moment. But back to you, Taz, for closing comments.
Well, I think just really, I want to really thank you all for taking the time to join me today for this conversation, and to hopefully that this is the first conversation of many that we're all going to have in this space, not only how we make sure care is accessible, but how we can really embed and improve the quality of cultural care no matter where we are. If you did have any feedback or thoughts or feelings, please pop them in the text box. Otherwise, thank you so much for joining us, and I look forward to seeing you as a participant at the next Birthing on Country seminar series.